Hi everyone, thank you for joining me today. Single sign-on for mission-critical applications accessed by millions of users. So that seems a bit presumptuous, I know, but I promise it's not a lie. But when you submit a session to Identiverse, you want it to be accepted, so you try to show off a bit. And it did get through. Yeah, thanks. So I'm Bertrand Carlier. I'm a senior manager at Wavestone. Wavestone is a company doing consulting services in the US, in the EU. As you can hear, I'm from the EU, and more specifically from Paris, in France. And I'm also an ID Pro member. I am a board member at ID Pro, and I'm certified ID Pro. So I love those badges, and you should come to me, and I will tell you everything about that after the thing. I'm not here to talk to you about ID Pro, but rather about something I did as a consultant, because as a consultant, I get to work every year on wonderful projects, different each time, and that's one of them that I want to talk about today. So the agenda is quite straightforward. We're going to talk about doctors in very different situations. Doctors that are alone in their own cabinet, doctors that are in the hospital, doctors that are using a laptop, other ones using mobiles. Pharmacies, they also get to access some healthcare data and applications. We have, so doctors in hospitals, doctors that have access simultaneously to several workstations, doctors that are going to share workstations. So it is crazy. It is, well, the use cases are impossible. That's just something you don't want to see. Or if you're a bit crazy like me here, it's a nice project to work on. And finally, I'm going to talk about a large-scale OpenID Connect provider that we designed and deployed to address everything here. And you can see here the login screen with the possibility to connect using a smartphone application or a smart card, or it says beta here, but it's going to go live in September with a FIDO2 token. It is a large-scale, go back. It is a large-scale OpenID Connect provider because it has over 1 million active users currently, and we are aiming for 3 times this in a few months. It has 300,000 enrolled users using their smartphone to authenticate. The other ones are currently using smart cards, and a very few of them are currently using FIDO2 tokens, but we want that to grow a lot. And we have over 50 million authentications every year, from year to year, for now 3 years in a row. So how did we get there? Let's go back to the 90s in France. Back then, the French government decided to deploy a nationwide digital scheme for all French healthcare professionals. And the main objective, I'm not here to lie, is to do cost reduction. Having paper-based prescription, having paper-based reimbursement system was costing a lot. And it was trucks and trucks of papers that you had to manage. So the digitization of this is the main driver why we had this scheme in France in the 90s. And there were efforts and investment in this so that every doctor back in the 90s already had a smart card. Each time they had their diploma, they were enabled to get the smart card automatically. And that's currently over 2 million smart cards. I think we are very close to 3 million smart cards deployed and active, and they're used every day. Every day when you go to a doctor in France, they use their smart card. They use your smart card, because I do have a smart card as a user. It's called Card Vital, and it's in my wallet here. And whenever I go to the doctor and I need to get a prescription and I need to get reimbursed, both smart cards go into a smart card reader with 2 readers inside, and we do digitally sign the prescription, or we digitally sign the reimbursement papers, and it works. Okay, now this allowed a lot of things to work correctly. This allowed the digitization of all this paper, and this had a profound impact on the ecosystem of healthcare in France. We had a lot of software developed for practitioners on their own PC. We had a lot of software, and actually they were developed in the 90s, in the early 2000 years. And a lot of those software are client-side. There was no web at the time, or it was not yet the advent of web, and we still live with this. Many softwares are monoliths, and there are desktop clients. So this is the situation right now that we inherited from, and this is something we have to take into account. If we fast forward to the 2020s, well, web application developed, and we were actually thinking about deploying an OpenID Connect server to let every vendor of healthcare solutions be able to connect to that OpenID Connect provider and provide a seamless authentication for all the doctors in France. This worked, and we had this deployed back in 2019 with like 20 applications connected and something like 100,000 users, active users. So very modest, but it worked. And then COVID happened. At that time, there was something that was developed to help cope with the pandemic. In particular, two systems. One to cope with the test, the COVID-19 test. Sorry. And one system, I'm sorry, it just, yeah. And one system aimed to cope with the vaccination campaign. So each time you went to a pharmacy to get a test, the results were input into an application that was connected to that OpenID Connect server. So every pharmacist was required to connect using our solution to that. Same for the doctors that did the vaccinations. They had to connect to this centralized application that enabled anyone in France to get a certificate, whether they were COVID-free with the test, or whether they were vaccinated and how many doses, etc. So this was a centralized solution that was deployed nationwide, and this made that our solution went up to over 50 million authentication per year. So we went from 2 million to 50 million in just 2 months, and it held. It just had one glitch. Of course, not the day we would have loved to have that glitch. It was the middle of the month of August in France, and in France in August no one works, but everyone wants to go on holiday. Everyone wants to book a train and hop on, and at that time to hop on a train you had to get your certificate. So everyone wanted to get a certificate, either they were vaccinated or they were COVID-free, and this went down just that day. But apart from that, we were cool. And that volume of authentication stuck. After the pandemic it's not behind, let's be honest. But after the pandemic was less an everyday thing, it's still stuck. Actually, now every application that is used by, the doctors know about our thing. ProSanté Connect is something that they know about. They know how it works. They know they have to use their smartcard or their phone. And we had, that's how we got the numbers we had today. We had to do some updates. We had to fix some bugs. We had to adapt. We had to make sure that everything was working specifically. And actually, one thing we added was the number matching, because we had fraud cases, because we had a push notification to the application without any number matching. We had people that were able to MFA fatigue the doctors, and the doctors just let them in at some point. So we had the number matching. It solved the thing. But it was always a challenge to monitor the solution and to make sure that we had the right numbers and that we were able to react in a timely manner to provide new updates. And we also had some ideas on how we would do with desktop clients, coming back to that, we knew we had a bucket full of desktop clients deployed already on the desktop and the workstation of the doctors, and we had to cope with that. So we had heard about the CIBA specification, client-initiated back-channel authentication, something like this. And we implemented that, and it works fine, but we didn't have a lot of adoption from the vendors that were developing those desktop clients. It was, I don't know, too complex, not the way they wanted to work. Anyway, it was still there. And we've been working also on, so we had there's now a mandatory connection required by the French government that every new service that addresses nationwide doctors, they have to connect. This service has to connect to ProSanté Connect. It's not an option, it's required. So of course, the number of connected services went really up. We included the CBAR support through the smartcard, which was quite of a technical challenge. And we had interoperability guidelines. We had FIDO2 support. We did the first test back in 2023, and now we are deploying a pilot. And in September, it's going to be general available for every doctor in France. So they will be able to come up with their own FIDO2 key and do something. So everything's great, right? But as I was saying, we have many desktop clients, aging software. We have a growing number of software that now needed to access modern APIs. And to do that interoperability, we didn't want to have those clients not connecting to our solution. We wanted to still promote the use of our solution. And we have a lot of use cases. As I was saying, we have doctors in hospitals that have to use several workstations in a single day. We have several workstations being used by several practitioners and shared workstation. We have roaming issues and context where to take into account. And if we do the math, roughly, a professional would have to authenticate something like 30 times every day he works. So that's clearly something that the healthcare department wanted us to address. And this is the mission we got. So we were tasked with reducing the number of authentication events for healthcare professionals using several desktop clients on the same workstation. Of course, web application as well. And we want some single sign-on between the desktop client world and the web client world. We also want, because why not, a single sign-on to the workstation authentication. We want that to work on shared workstation. We want that to work on a roaming context. So basically, it was quite the mission impossible, but we were still asked for it. So we had to do the study, and we had to come out with an answer. So if we recap very roughly, this is what we had at the start. We had a nice SSO bubble below for web clients. And then so we could authenticate to the workstation, first authentication, then we had to authenticate to this nice web SSO bubble. Then we had to authenticate to a first desktop client. Then we had to authenticate to a second authentication client. Then we had to authenticate to any number of desktop clients. So that's a lot of authentication. So the first objective was to try to create a new bubble around the desktop clients. Like if I could authenticate once and have access to all my desktop clients at once with just one authentication, that's only 3 authentication that I still need to do every day. One for the workstation, one for the desktop clients, one for the web clients. So that's better. And of course, my session timeout or my session max time has to be taken into account. But roughly, this is 3 multiplied by the length of the session, the number of sessions I have to maintain active every day. And then we were asked to extend this bubble and to merge the 2 bubbles, web clients and desktop clients, and then we were asked to extend this bubble to the workstation SSO. And we had 3 approaches in the study that we had. So either do nothing, like why can't the application just implement what exists today? There is an RFC for this. Or we could resuscitate something called NAPS. So if you were here 10 years ago, you might have heard of NAPS, but I will go into some of the details after that. Or we could do something like reversing the trust. I'll come into the details. So do nothing means there is the RFC 8252, OAuth2 for native apps. It says to the native apps, just pop up a web browser, authenticate there, and you get your token. And the next application can do the same thing. It's going to pop up the browser, the same, with the SSO session, and you're going to have access to, you're going to have your token. So it works like this. I can access different type of applications. I authenticate centrally on my ProSanté Connect server, and I can use either my smart card or my push notification to the phone. It's already available, but basically it didn't work. We were trying to promote this to vendors, but they didn't want to implement that for whatever reasons, good and bad reasons, let's say. And it does not support the workstation single sign-on. So it's only going to work for single sign-on between desktop clients. It's not, and web clients. It's not going to do the session. So the other approach is to use to share a single token across every client. So basically, you're going to do something like the first client is going to ask for. I'm sorry, it's small here. Okay, so the first client is going to require to some agent, to some binary that you installed on the PC before. It's going to ask for a primary refresh token. It's basically like what Microsoft does with Azure AD or Entra ID enrollment. So the first client is going to ask, do you have a primary refresh token, a PRT? And I'm going to answer no. Okay, I'm going to do a CBAR request. I'm going to do a notification, whatever, to my server, and I'm going to get both a token from my application and that PRT. Then I'm going to hand over to my binary agent that is sitting on the and running on the workstation. And then when the second client is going to try to access to the application, I'm going to hand over a token. I'm going to that PRT. I can use it as a login hint to the central server, and I'm going to have SSO. So I have to request for it, but it's invisible to the user, and I can get a new token from a new application. I can refresh that primary token so that it maintains the session kind of active over time. And basically, it works. We developed a proof of concept for this. It was greatly inspired by the specification here that's still a draft from something like 10 years ago. It's really very inspired by what Microsoft does with Entra ID joined workstations, and we had them challenge what we wanted to do, and they were saying, yeah, that's basically what we do. It's well, be careful about this and this, and so we developed that, and we tried to see whether we could support that in the long run. But basically, it was, yeah, as you can see, a bit complex. The cinematic here is quite complex, and anything can break anytime, and you have a lot of moving parts, and you have to support all the moving parts that you have to develop. You have to support maybe a web browser extension, things like this. So it was going to be a mess in terms of support. It was going to cost a lot of money for us to develop that and to support over time. So that's not the solution that we went with, and we decided to. We explored a last scenario, which was so federate with the hospital's identity providers. So like instead of connecting with the smart card that is government issued to every doctor, I'm going to allow people to connect with their hospital issued credentials. So the user is going to access to the application, which will delegate the authentication to ProSanté Connect, which will delegate the authentication to the hospital's identity provider. And I'm going to use here a local authentication factor. So this is really something important to understand. It's really a leap of faith, because you have to trust every hospital that you want to join the program to be able to secure correctly the life cycle of the identities of the doctors, to provide credentials that are sufficiently hardened, because we don't want to replace a smart card or a FIDO2 token by just a password. So we want some insurance. We want to be able to trust those hospitals. And basically, it's very hard to say that you're going to trust 50, 100, 200 different hospitals that have for some of them, a very low maturity in terms of cybersecurity. So that was really something that it made me quite afraid at start. But I saw that people at the government were not so afraid about this. They were saying, as long as we have the safeguards, as long as we tell the hospitals how they should secure their IDP, their life cycle, we might explore this solution. So it was quite good to get this feedback and to explore furthermore the application. And actually, we ended with something a bit different than what I just presented. So the idea is still to federate to hospitals, local identity providers, but once in a while, something like every 3 months right now, we're going to ask the doctors to pair their government-issued credentials with their hospital-issued identity. So we're going to ask them, is it, the hospital tells me this is you, is it really you, and prove it to me using your official smart card, using the push notification, using the FIDO2 token that I issued to you. And that's the solution we're actually deploying right now. And actually the FIDO2 authentication is based on this very mechanism. So we're going to deploy that. We are already in production. We are going to, in the next phases, explore mobility and offline scenarios because doctors, we focused first on the hospital doctors that have a reliable connection, that have very specific use case regarding to their workstation, but now we have to address doctors that are moving around in the country and that are sometimes offline when they do something with the patient, when they want to issue the prescription. Maybe they don't have data connection at that very moment, so how do we deal with this? We're currently studying to have ProSanté Connect as what we call a substantial authentication authority, substantial in the terms of eIDAS, which is a European regulation that sets different level of authentication strength. So we want ProSanté Connect to be substantial, which is the second level in that regulation. And we want to, actually we did start to do that. The pharmacy use case is something quite tricky as well. So you have people in the pharmacies that are going to log in with 2FA in the morning, and then they have 4 hours that they can only do 1FA, and it is just like if it is 1FA. Actually, they are using a contactless card that they have to enroll in the morning with 2 factors using the chip, the contact chip. And we put a token on the card that is readable and readable only with the contactless antenna. So we have the people carrying actually a token, a physical token containing a digital token on this. And we want to address that further and to make it compatible with the ProSanté Connect, because this is bespoke solutions locally at pharmacy with proprietary implementations. And we're going to continue to optimize things. And one last thing I wanted to mention is that we have a very diverse population with very diverse use cases, and we know and we are sure that we cannot have one solution that fits all people. So we have to adapt. That's why we provide smart cards, we provide push notifications to phones, we provide FIDO2 tokens, and we're going to let the hospitals decide whether they want to embrace their credentials or they want to stick with what works now. And we have to keep that flexibility. And with that, I would say thank you.
Bertrand, excellent stuff. Really appreciate it. Folks, I know we have a beer crawl coming up, and I don't want to stand in your way, but we do have time for a couple of questions. If you want to ask something, raise your hand. I'll bring you a mic. Okay.
What prevents the use of synced passkeys in this solution?
What prevents the user from using passkeys?
Synced passkeys. Yeah.
Synced passkeys. The timing. We studied that 2 years ago, and passkeys have been announced 2 years ago, and they have evolved every 6 months. Passkeys is not the same thing as it was 2 years ago, so that's probably one of the most.
It wasn't a regulation thing.
No,
Okay.
no. But actually, it might be a problem because currently the authentication has to be hardware bound, and it is it's not a regulation, but it is how the states wants this to happen. So we have to change that text before we can make any other option.
So question, was the government of France okay with version 3.0, or did you have to go to 3.5 with the linked? Did you have to go to version 3.5 with the linked smart card to meet any sort of regulatory requirement?
Yeah. Actually, so same thing. It's not regulatory. It's not by law, but it's a text that the government issued at some point. So it's not the Parlement. I'm sorry. It's not the Parliament. It's not a law by the Parliament. It's just a text by the government. So it can be quite easily changed if the government is okay. But it still currently requires that this is a government-issued credential that you use to authenticate. And we have an exception made for our current pilots, and that text is going to change in September, so we can be generally available for every hospital that wants to use. All right.
I'm sorry, we're out of time. Thank you all very much for joining us. Enjoy the rest of the show. Bertrand, thank you very much.
Thank you, Greg.
Enjoy the networking reception in the expo hall, and enjoy the beer crawl. Don't overdo it.